Hi, welcome back, everybody. I hope that you enjoyed your break. It's Dr. Jody Carrington here. I'm your host for today, and what a great morning. I hope you enjoyed the poster session. I want to remind you about the networking at the end of today, which is sponsored by Simon Fraser University. I want to jump right into our next session. I'm so excited for you to meet this phenomenal panel. The title of this first part one section is Better Together, Reflections on Building Strong Partnerships in Research. And this session will feature a panel discussion from the KBHN project called Partnering in the Co-Creation of EDIT-CP, which is Early Detection and Intervention Toolkit, Cerebral Palsy. And I think, that this panel discussion today is really going to highlight the interplay of researchers, partners, and community organizations that strengthen implementation and synergistic impacts for projects and their communities. I'm so excited to introduce you to which is much easier said than done apparently, to the moderators. Dr. Annette Meinemer, she is the Vice Dean of Education for the Faculty of Medicine and Health Sciences at McGill University and professor in the School of Physical and Occupational Therapy. As well, I want you to meet Dr. Darcy Fellings, who is the head of the Division of Developmental Pediatrics and is a professor in the Department of Pediatrics at the University of Toronto. Over to you, Dr. Meinemer and Dr. Fellings.
Great. Thank you so much, Jody, for that warm introduction. And I'm going to start off with a few comments. I'm Darcy Fellings, developmental pediatrician from Holland Bloorview Kids Rehabilitation Hospital. And we are really excited to be bringing to you something we think is really important, the early identification of high risk of cerebral palsy, and importantly, how that facilitates linking to early intervention. Next slide, please. So we have neuroscience that shows us that early intervention really maximizes the impact. But what's the status in Canada? The average age of a diagnosis of cerebral palsy is close to 19 months. And in today's world, that means a late diagnosis of cerebral palsy. So we have clinical practice guidelines that exist that allow us to detect CP as early as 5 months. Now, importantly, this clinical practice guideline really speaks to children followed in the high-risk neonatal intensive care units and also linked to neonatal follow-ups, which raises the question, what about the children that present in primary care practice that don't have this developmental surveillance? So early detection of high risk of CP is important only if it links to early intervention. And so this project really focuses on these two aspects. And here we have a little example of an early intervention, which is baby constraint. Next slide, please. So in our panel today, we've split it into two sections. Annette is going to lead the first section on the primary care pathway, children who present to primary care with some delays in their motor development. And then in the second half of the panel, we're going to be talking about the high-risk pathway. So without further ado, I'm going to turn it over to Dr. Annette Meinemer.
Thanks, Darcy. So as Darcy mentioned, recent data in Canada shows that diagnoses occur late for children with cerebral palsy, which means that interventions are delayed and family supports are also delayed. And we know we have evidence both for low risk and high risk populations that there are ways to detect these children earlier, and there are a variety of evidence-based early intervention strategies. So we're developing a new toolkit called EDIT-CP, which will provide some strategies for early detection, both in the primary care context and in neonatal follow-up, as well as tools for rehabilitation specialists in terms of early interventions. So in line with the theme of this conference on partnerships, I just want to acknowledge that these different areas have been done in partnership with experts in cerebral palsy, in methodologies on knowledge translation, but importantly also with knowledge users, with clinicians, primary care providers, rehabilitation specialists, and families. So to hear more about it, I'd like to introduce our three panelists coming next. So first is Dr. Zachary Boychuk, who's an occupational therapist and a postdoctoral fellow at CanChild. He will be followed by Dr. Tatiana Oburtsova, who's also an OT and a site researcher at the Jewish Rehabilitation Hospital and an assistant professor at the School of Physical and Occupational Therapy at McGill. And Emma Stephen will provide a clinician perspective. And she is an OT at the Lethbridge Leighton Mackay Rehabilitation Center and works in 2 specialized schools for children with physical disabilities. So first we begin with Zach, who will talk about early detection in the primary care context.
Good afternoon, everyone. Thank you for this opportunity to come and share with you pretty much my doctoral research. The prompt study had 2 main objectives. The first one was to provide an evidence-based and population-based understanding of primary care practitioner referral practices for children suspected of having CP. Specifically, we were interested in identifying potential predictors of delayed referral or children who were experiencing prolonged referral. The other aim was to develop expert-informed content for educational tools designed for primary care practitioners and parents, specifically to help identify what the early clinical signs or attributes of CP are that should prompt referral for diagnosis, and concurrently what other referrals can be made at the same time as the referral for diagnosis to decrease any delays that currently are experienced there. So we ran 2 consensus groups with Canadian experts, including all of the stakeholders who Annette just mentioned. So medical specialists, primary care practitioners, parents of children with CP, rehab professionals, researchers. And we came up with 6 attributes or signs that should be sort of red flags, 2 warning signs that warranted closer monitoring, and then 5 referral recommendations to be made concurrently at the time of referral for diagnosis. To make sure that this evidence was generalizable beyond the Canadian context, we ran an international validation study of this with experts from around the world, and the evidence held. So what we're doing is taking this evidence and turning it into easily user-friendly, stakeholder-friendly knowledge translation tools. So for example, I don't know if you can see my cursor here, but typical development, atypical development. If you see any of these red flags that we've identified, it should be a flag to refer the child for diagnosis. So for example, early-handedness before 12 months of age, red flag, refer the child for diagnosis, and then we have concurrent referral recommendations to go with it. So what we're doing right now is we've been partnering with stakeholders, so pediatricians, family practitioners, OTs, to determine the content and format for these tools, again, geared for primary care practitioners and parents. We've been synthesizing the feedback and developing these tools. We worked with a medical illustrator. We partnered with users and experts, so parents and physicians. Incorporated their feedback. We used a panel from the researchers from the prompt study as a sort of sounding board and used their experience. And we're currently working with a graphic designer to really tweak this into multi-formats that can be distributed and disseminated across different stakeholders, and hopefully will be used. We're also working with the authors of the Rourke Baby Record to get these tools incorporated in there so that it's disseminated across and widely used across Canada. So off to Tatiana.
Thank you very much, Zach, to present to us the early detection. So now we're off to looking at the evidence for early interventions. So the goal for us was really to determine the effectiveness and the level of evidence for different early interventions, and also to classify those by CP type and severity. So in collaboration with 2 research assistants who are also occupational therapists, and one of them is here today to give us her clinician perspective, we conducted a literature search, we extracted the data, we rated the quality of all of the studies, and we synthesized the data into those what we hope are user-friendly, evidence-based knowledge translation modules for clinicians, but also for patients and families. In fact, we're working in collaboration with parent partners to ensure that the modules for patients and families are relevant, suitable, and also understandable. So let me show you an example of such a module. So for instance, if we take modified constraint-induced movement therapy as one of the early interventions, we would have an introductory statement about this particular approach. Then if we click on patient and family information section, what we will see are those different questions, typical questions and answers that family members may ask themselves about this intervention. For instance, what is modified constraint-induced movement therapy? Is this appropriate for my child? Are there any side effects and risks? So this is in fact the section where we're working together with parent partners to ensure that those are the right questions, that they're being asked in good ways, and that the answers are understandable and it's user-friendly to navigate the platform. We also have a clinician information section. So if we click on that, it's going to take us to this more detailed page where all of the outcomes that were studied are listed, the effectiveness is listed, and the level of evidence appears. Of course, that depends on the quality of the study. Users also will have the ability to download a PDF of a much more detailed results table. And there's also a possibility to expand on the outcome. So let's say if a user clicks on hand manual abilities, it will take them into this more detailed page about the actual study, what measurement was done, how long the intervention was provided for, and what was the result. And also we can see that there's a conclusion about the level of the evidence. The users also have the opportunity to click on the underlying terms to get a definition of those terms. So for instance, if a clinician is wondering what is level 1B evidence, they have the opportunity to click on that, and it will take them into a sort of a dictionary where the term is described, and there are also different pictures to make the information more understandable. So now off to Emma for her clinician perspective.
Hi, everyone. I'm really excited to have the opportunity today to share with you my perspective on the Edit CP Toolkit. When I was working on this as a research assistant, I thought frequently about how useful of a tool this would be for myself, for my colleagues, and for families. As clinicians, we obviously want to make sure that we always are using and recommending the most up-to-date interventions. That's really based on high-level research. However, finding the time in our super busy days to do the research is certainly a challenge. So this tool will be a much more efficient means for clinicians to access information of the up-to-date research, and I really believe it will lead to more effective interventions. The tool will allow us to fortify our evidence-based practice with the most up-to-date information. And so, as Tatiana was saying, the information will be updated on a regular basis, and I think this is one of the reasons that the tool will be so successful. Being empowered with this information that is already being digested, so as Tatiana explained, pertinent information will be extracted, the level of evidence rated, the results analyzed, and even it will specify the type and level of CP. Having all of that information and having access to it in a quick manner will definitely help us ensure that we use the right intervention. But furthermore, I think it will also help us advocate for our clients within the healthcare system. The other thing that I really want to highlight is how great a tool I feel this will be for families. It's a place we can send them so that they can find current research and up-to-date information. And as Tatiana explained, certain parts of it were specifically made for families and clients. So it really is made in a format that is client-friendly. So I'd be comfortable sending my clients and their families to it. And fortunately, families are often very engaged partners in their children's rehab process. And this is such an important part. And as we all know, more and more people look things up online. And so what we want to ensure is that the information that they're looking up is accurate and that it's based on evidence. Because when what they look up is not accurate or is not based on evidence, it can really have a negative impact on their child's rehab process, but it can also impact our therapeutic relationship with them. So having a tool like this that is based on evidence, I think is crucial. So I'm really excited about this tool. I'm excited for it to be launched because I really believe it will have a direct impact on client care and on clinical practice.
Sorry about that. Okay, so we're going to have our question period now. Sorry about that delay. And until we see some questions, perhaps I can get us started. So as Zach and Tatiana, Emma alluded to the importance of this tool for families. Can you describe a little bit about how patient partners have been involved in the development of your toolkit? So in terms of early detection, tools for primary care providers and the early intervention tools that are being developed, in what ways patient partners have been involved and continue to be involved.
Zach, you want
So
to go
maybe we'll
first?
start with
Early detection?
Yeah, sure. Great question. Also very important. I think it's a question we should be asking in all of our research. I mean, our prompt study was integrated KT through and through. I mean, we had stakeholders and users involved in every level, from the grant moving forward through every phase of the study. In particular for me, I think back to when we did the national consensus groups, and we had parents at the same table as, you know, the some pretty big names in the field of CP research, whether they were clinicians, researchers, you know, site leads of the Cerebral Palsy Registry. And the feedback that we got from parents was that, you know, to be sitting at the same table and being given an equal voice was something that they appreciated, but was also something that was, you know, surprising to them. Which, you know, as a younger researcher, that's something that really struck me as, and again, as an OT, I can't take off my OT hat, and to have end users and stakeholders involved is not something that I find novel, but it does seem to be in research. So as somebody who works in KT and partnership and engagement research, I find it really encouraging that this seems to be something that's being embraced, whether it's at CIHR level or across these different projects, especially, you know, what we're seeing here today. I think I'm preaching to the choir, but yeah, to answer your question, we had parents, stakeholders, families, primary care practitioners involved through every phase of our study. But what really resonated with me was how important it was for them to, you know, be given those opportunities when I think they should be. They don't need to be given them; they just need to be given a seat at the table or afforded one. And I think we can do better. But I think as a starting place, it was an awesome experience for those of us involved, especially if we're more junior.
I agree, a win-win. What about you, Tatiana?
So for early intervention, we are in the process actually right now of recruiting 2 parent partners, and we're aiming for those people to be parents of young children with cerebral palsy. And the goal, how we structured this collaborative work with them, is that some of the questions will already be designed, some of the answers will already be designed, and we're going to get their feedback. But it's also very important for us to see, have we missed anything? So them as parents, when they hear the term constraint-induced movement therapy, what is the first thing that comes in mind for them as parents of children with CP who might be getting this treatment? So we're really going to get their first impressions, and also their feedback about the question and answers that were already developed, and adjust according to their feedback, of course.
That's great. So there's a question, where can families find this tool? So perhaps you can update on where we're at in terms of going live.
Is it for early detection or early
yes.
intervention?
I think the toolkit as a whole. I guess I could, yeah, go ahead, Tatiana.
So the toolkit is in the process of being designed on the web, and it's going to be connected to a childhood disability link. So it will be available there in, I guess, a couple of months.
Okay, so to begin to look out for it in the spring, and we'll make sure to indicate the launch through KBHN Network, Child Bright, and other networks across Canada. So there's another question for the toolkit. Once it becomes available, what what can we do for those who don't have reliable access to internet or who just aren't that tech savvy? Any thoughts about that?
Yeah, so we have thought about it, and there will be an option of downloading every page in a PDF format and printing it. So this is something that families can request when they are at their visit with the clinician to, let's say, print them the module on a particular early intervention or the module on early detection and have it in printing. So everything that will be accessible on the website will also have the PDF printing option.
Great. Any other questions from the audience? Zach, how will you know that your tool is actually making a difference? So if we have this primary care provider toolkit, which might be a pocket card, a website link, posters in the waiting room, so whatever formats we end up using, how will you know it's actually making a difference in terms of diagnosing children earlier with CP out in the primary care context?
Very good question. Very important question. I see two different ways of going about measuring that. The first one being that we built variables into the Canadian Cerebral Palsy Registry, which will now be looking at age at diagnosis and age at referral, age at diagnosis, and then age at rehab, referral and initiation. So in like maybe 5 years, once our tool has been out, we can look at the numbers and see, at a population level, whether they've decreased, like age at referral has decreased. I think we could also use a more KT type approach. Something even as basic as using clinical vignettes, exposing, whether at the med school level or early practitioners, case studies, give them the tool, pre-post, simple, but seeing if, whatever shape our tools end up taking, seeing if they do actually increase awareness or education or knowledge of what we think that we're passing along. And then we can adjust accordingly. But even something like, simple pre-post, case vignette, medical education type approach could be interesting to explore.
Okay, great, thank you. There's another question. For early intervention, is there a plan to state the evidence or lack of evidence for other interventions that Emma alluded to?
Yes, absolutely. So given that we were able to rate the quality of all the studies that are included, we can see if it's level of evidence 1B or level of evidence 5, meaning that there are no high quality studies. So since users will see the level of the evidence, they will also then understand where the lacks are, where the gaps are, where more high quality studies are needed. Yeah. So the example that I showed you was constraint-induced movement therapy that has high level of evidence, but of course not all interventions have this kind of research completed, and there are lower levels of evidence that exist.
And there are about how many different intervention types that you're looking at? Just to give a sense of the scope.
Yeah, we have about 24 interventions right now that are part of the modules already. Yeah.
Okay, thank you so much. So I just want to thank Emma, Zach, and Tatiana for their input and expertise. And we're going to hand it over now to Darcy to talk about high-risk infants.
Great. Well, thank you for that. That was a whirlwind tour of two really important tools for identifying children early in primary care practice, and then really developing this Edit CP toolkit to help to support parents and clinicians in the real world. So I think it'll be fabulous. So what we're going to talk about now in the panel is a focus on children who are in this high-risk pathway. We're going to focus on hemiplegic cerebral palsy so that we can try to make it alive for you. And hemiplegic cerebral palsy is our most common type of cerebral palsy, representing just under 40% of children with a diagnosis of cerebral palsy. So in the panel for the high risk, we have Amber McKeno, who is a developmental pediatrician at Holland Bloorview Kids Rehabilitation Hospital, and Sophie Lamdanji, who's an occupational therapist, also at Holland Bloorview. And then we're also joined by a parent, Shauna Haley, who will provide her perspectives on our early intervention that we're going to be talking about, baby constraint. So next slide. So I just wanted to give you a visual around the high-risk pathway as it relates to hemiplegic cerebral palsy. So here we have the neonatal follow-up, and one of the key tools in the clinical practice guideline is the Hammersmith Infant Neurologic Examination. And it allows early identification of high risk of cerebral palsy as well as hemiplegic cerebral palsy. And then that early identification allows an early linkage to an evidence-informed intervention called baby constraint. So we can close the slides now. So I wanted to throw the first question to Dr. Amber McKeno. So Amber, can you tell us about the Hammersmith, how it fits into the clinical practice guideline, and why you think it's a good tool?
Sure, of course. So the Hammersmith Infant Neurological Exam, or I'll call it the HINE for short, it's an easy to perform exam that's used for infants 2 months to 2 years. And as Dr. Failings mentioned, it's especially useful for early identification of cerebral palsy. And it's been integrated into the clinical practice guidelines for early diagnosis because scores on the HINE can be used to predict future CP in infants as young as 6 months, or with about 90% accuracy on its own. And then when it's used in conjunction with other tools like an MRI or general movements assessment, which are often used in these high-risk infants, it can be used even earlier and with even higher accuracy. And there are many features of the HINE specifically that I think make it a really practical tool. So it only takes about 10 minutes to perform and score together. It's fast, it's easy to learn, and it doesn't take extensive training to learn it. And also there's a scoring sheet and resources to learn the tool that are freely available. So this means it can be used in lower resource settings and that it can be administered by different team members. So not only physicians, but therapists or nurse practitioners. And it's also got a quantitative scoring system that was designed through research, which gives it some useful prognostic values as well. So not only can we predict CP, but certain scores also can predict the motor impacts on functioning. So for example, we know that scores above 40 on the HINE are predictive of a child being able to walk or ambulate in the future, which is really important. And we also know that some types of CP, such as hemiplegic CP, which we're focusing on, can be harder to predict by some of our more traditional means. And so because children with hemiplegic CP, they often compensate with their good limbs that are typically functioning. And the HINE is able to pick up some of the asymmetries in motor function. And there is an asymmetry score that's part of the HINE. And that's been shown to predict future CP as well.
Oh, thanks for that, Amber. That was a response that really embedded a lot of information in it. So the theme of this conference is about partnering. So who have you been partnering with to help get the Hammersmith into practice?
Sure, yeah. So in order to support early identification with the HINE, we've partnered with our neonatal follow-up teams, who are the clinical teams following the high-risk infants. So we started locally. So here in Toronto, we have 3 level 3 NICUs in Toronto who refer to our early intervention programs. And some NICU programs were already using the HINE. and others weren't. So for those who were not as familiar, we co-facilitated and offered webinars on how to use the Hein along with our neonatology colleagues. So we have a colleague, Dr. Karen Thomas, who works out of McMaster Hospital, helped co-facilitate that webinar. And then at the same time as working locally, we have a provincial community of practice that was initiated as well with level 3 NICUs and children's treatment centers around the province. So far we have partnerships with Holland Bloorview and Sunnybrook in Toronto, McMaster Children's in Hamilton, CHEO in Ottawa, Children's Hospital in London, Kids Inclusive in Kingston, and Thames Valley Children's Center as well. So, and we partner with the physicians there and the OTs there at each center, and they work to lead a program in their own area, partnering with their own local early intervention programs, neonatal teams, and children's treatment centers. So every jurisdiction has their own unique population and models of care, but we come together to problem solve and share successes in monthly meetings.
Great. Thank you, Dr. McKenna. So I'm going to turn it over to Sophie Lamdanji, occupational therapist. So Sophie, can you tell us what baby constraint is and how you've seen babies respond when you've been working with parents and the babies?
Thanks, Darcy. I'm very excited to talk about baby CIMT. So baby CIMT is an early activity motor-based intervention for infants at risk of or with a diagnosis of HCP. And it includes blocking the stronger, preferred, unaffected arm and hand, pairing that with structured motor practice. And the goal of baby CIMT is to improve motor control in the affected arm and hand to impact bimanual performance. In my practice, what I've seen is at follow-up visits, I have heard from parents as well as seen improved spontaneous use of the weaker arm and hand for reaching, contacting, touching, holding, and actively grasping toys. And this is very important for infants at a very young age because one of the biggest things that they do is play with toys. And these changes are actually captured on standardized reassessment tools.
So again, linking back to the theme of the conference around partnering, who do you see as important partners in carrying out baby CIMT or constraint programs?
That's a great question. For baby CIMT programs to be successful, I believe it should include a team of the parents as well as allied health professionals, and that includes at Holland Bloorview a developmental pediatrician who oversees the general development of the infant, an occupational therapist who does a very careful assessment of the infant and develops a personal kind of just right challenge for the baby CIMT program. But the most important partner is the parent. The parent or the caregiver is the one who will be implementing the baby CIMT program at home. They are the ones that knows their babies well and can really explode those natural opportunities during the day to implement that repeated practice that we need from baby CIMT to impact motor outcomes.
Great, great. Well, you've highlighted the importance of parents. So let's move now to hearing from a parent themselves. So we will return the floor over to our video of a parent who's spoken about baby constraint.
So welcome, Shauna, and thank you for taking the time to answer a couple of our questions related to your experience with our baby CIMT program at Holland Bloorview in Toronto, Canada.
Absolutely.
So first question, can you describe your perspectives on the baby CIMT intervention for your child?
Sure. I had a really great experience using the baby CIMT program at Holland Bloorview. We had been looking for something similar pretty much ever since we first had some suspicions about what our son's diagnosis was when he was a few months old. He was officially diagnosed just over a year old. That we were referred from Sick Kids to the program at Holland Bloorview. We were doing 30 minutes a day, up to 30 minutes a day with the constraint on. And we found it very effective. We started noticing improvements within, I think, a few weeks of using it. In addition to just when we were working with him, seeing those improvements, we also noticed them just when he was playing on his own after too, whereas before he would often neglect his hand quite a bit and play mostly with his dominant hand. We started noticing pretty soon after starting the program that he was on his own, taking his affected hand and using it to play and as a helper hand as well. And we had never seen him doing that before unless we had prompted him to do it. So that was a really exciting thing to see as well.
That's very exciting to hear the spontaneous integration of that hand and how great that hand has come along as a helper assisting hand. One last question, being the primary person to carry out the Baby CIMT program at home, what are your thoughts on the partnership between yourself, the Baby CIMT clinic, and especially the occupational therapist?
I think it's really important to have that relationship. It's definitely challenging doing the program at home and being the primary person doing that. You need to find the time every day to do that. And especially if you're a working parent or you have two working parents in the household, it can be really challenging. It was really important to have that relationship with our occupational therapist, just to troubleshoot some of the things that came up along the way, to have that person doing like the measurements and the evaluation of the hand function, kind of like a statistical way to see measurable improvements. That was really helpful and very motivating because it is very time intensive, and it is such a labor of love that it's really helpful to feel that encouragement, like, okay, it is actually helping, this is worth my time, it's worthwhile to do this. As well as having the therapist there to help come up with activities to work on those specific goals and to give you the specific goals to work on so that you know how to focus that time. And along with troubleshooting problems that come up along the way.
Shauna, I think you said that very beautifully. I've really enjoyed the partnership with yourself as well. I think you've done a great job with your son.
Awesome, thank you. We couldn't have done it without you, Sophie.
Thank you, Shauna.
It's always so great to have a parent voice, just brings things home. So thank you, Shauna, for sharing your perspectives. So please post some questions in the Q&A and I will get the discussion started. So maybe the first question I'll throw to Dr. McKenna. So can you tell us a little bit more about the community of practice, what it is, what it means, and how you've found it helpful?
Yeah, for sure. So it really is a community where we're meeting as a group of clinicians who are kind of going on a journey to start a new program. And so, as I'd mentioned, it is physicians and occupational therapists, and it's a growing community. So it started smaller and grows month to month. And we talk about some of the barriers to maybe implementing a program at first and getting it running, about how we can build partnerships with the early intervention teams, and then also sharing updates and coming up with some consensus about what are some important criteria for referring to Baby CIMT program, and that's always evolving. And we're trying to sort of track as a group when children are being referred to the Baby CIMT program, how many children are being seen through that program, and are being seen in follow-up. So we're getting a sense of how successful the implementation has been as a group.
Great, great. Yeah, I've found it to be very practical. So anyone trying to do knowledge implementation, these community of practice meetings are really, really helpful. Sophie, I see a question in the Q&A related to how effective is it to provide baby constraint virtually or over telehealth? And I know you've had some direct experience with that given the pandemic.
That's a great question, given the times that we are in now. So Holland Bloorview, we were able to pivot quite quickly to provide some virtual services for our babies and families. We were able to, I guess, really take a look at the assessment and pick out those careful aspects that we could do virtually. So if I were to give some practical ideas of how we did it, is that we would ask the parents, we would engage with the parents ahead of time over a telephone just to get an idea of what the baby is doing, what are the parent concerns and what are their goals. We ask for consent to speak with their community-based clinician. And the community-based clinician is also invited to join that assessment virtually. During the virtual consultation, we also ask the parents to have the baby in a space where we can see the baby move around a little bit, and the parents are asked to have available some easy to grasp toys and toys that the babies are interested in. And through the virtual consultation, I asked the parents to demonstrate a few things. So I would demonstrate it on screen and then the parents would copy it. I would ask the parents to position toys a certain way just so I can take a look at some of the motor movements. I certainly couldn't do some of the hands-on assessments, so we would pair the virtual visits with an on-site visit. But overall, the parents found the virtual visits to be quite easy to do, and they really welcomed the ability to have access to the Baby CIMT program virtually.
Great. Thanks, Sophie. Dr. McKeno, next question is going to be for you. So for the clinicians in the audience, so physicians and therapists and nurses, nurse practitioners, how easy was it for you to learn how to do the Hammersmith? And what perspectives would you have to allow clinicians to develop this as a new skill if they're not familiar with it?
For sure. Well, I think for me, the biggest change in practice that goes along with just the new practice guidelines is that I started to see younger infants. So having a standardized way to examine younger infants was really important. So we were lucky to have a training program come to Holland Bloorview, and I was able to do that. And it was a pretty quick training program. So we were able to learn and practice the exam within a day training program. And then it took probably about a dozen times practicing with a partner who was also learning, which would be Sophie, doing the exam before I started to really feel comfortable. I think if you have experience working with infants or with children, you kind of know that there are standardized aspects of an exam, but you always have to be flexible, and so that's important with this tool as well. But it's nice to have a standardized way to assess infants, so it's been really practically very helpful, and it's quick and easy to learn.
Great, great. Yeah, I think that's one of the really cool things about the Hammersmith is that it really can be applied effectively in a clinical practice setting because of the ease of doing it, and can also be rolled out in low to middle income countries as well. So it's quite flexible for many settings. So Sophie, there's a Q&A in terms of, what is the evidence, or what are the plans to look at the evidence for the long-term impact on baby CIMT?
That's a great question. So right now there is quite a bit of evidence for baby constraint-induced movement therapy. I can highlight a couple of articles. One is the Iona Novak article, and she summarized over hundreds of treatments for children with cerebral palsy, and she summarized that evidence into a bubble chart. And if you do get your hands on that article, it will showcase that constraint-induced movement therapy is showing some great promising evidence for infants under 2 years of age. We certainly know that CIMT for children over 2 years of age has huge volumes of evidence. And then Darcy talked a little bit about the clinical practice guidelines, and there was an article that came out in May of 2021 this year that really summarized and highlighted the strong evidence for baby constraint-induced movement therapy that is distributed in kind of short training intervals. And the clinical practice guidelines also highlighted a lot of strong evidence for early activity motor-based interventions, which baby CIMT certainly falls under. In terms of future, looking at the long-term outcomes from a Holland-Blurby standpoint, there's been discussions around looking at the assessments, the change in the scores, if there are any, and then putting our heads together to maybe take a look at studying that.
Great. Thank you, Sophie. Well, I'm just looking at the time, and I really thank everybody for all their comments, informed comments, and all the Q&A. It was really great. So without further ado, I will turn this back to Jody.
Thank you so much. Oh my goodness. I am Annette, Darcy, the entire panel. I'm so struck particularly by the connection between families and the research. I think oftentimes there's such a disconnect that happens there between, those of us in frontline clinical practice and what that looks like in the research world. And phenomenal work has been done. And what an honor to sit and listen to this really insightful panel. I also love the questions, and so keep those coming. The interactions. I mean, we love that as presenters to hear from you. So I now want you to. We're going to step into a 5-minute transition again. Step up and out, get a coffee, shake it out, come on back to us, and then I'm going to invite you just to click on the left-hand side of your panel when you're ready to come back to us. We're now going to step into a number of the second part, sort of around ABLE2's Fetal Alcohol Resource Program. It's a stakeholder-driven project as well to support children and youth with FASD and their caregivers. And so the tab is again in the feed loop, and I hope you'll be back to join us there in just a few minutes.